Hello gamers, welcome to Global Academy of Medical Education, and today we are back with one more Obs-Gyn high yield topic, the Partograph. So my name is Dr. Sunabha, your Obs-Gyn faculty. So Partograph is one topic that has always remained high yield and recently underwent major change. Not only major change, I would say a paradigm shift. So can you see this graph there? I will come back to it again. If you have noticed that there was the husband and the wife who is carrying the baby, so now husband is also included in our every planning and management of the labor. So this is your WHO new partograph. This is your WHO new partograph, which is known as new, but because it replaced the WHO old partograph, but this is no longer new and this has been replaced by something else that we'll discuss later. So let us just recap what are the characteristics of it. So patient information data, name, hospital number, date of admission, time of admission. This is, remember, to the labor room, right? And ruptured membrane for how many hours, and basic labor parturient characteristics like gravida and parity. So the first section was the fetal parameters, fetal heart rate. So this is the area where fetal heart rate is plotted. There are two small boxes for amniotic fluid and molding. So molding can be only written in plus, plus, plus and plus, plus, plus. And amniotic fluid is either molding is plus, plus, plus and plus, plus, plus. Plus is when there is the fetal heart, the fetal skull bones just apposed, there are no gap between them. Then plus plus is when they override but can be pushed back to their place, and plus 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 is when they override and even with pressure they cannot be pushed back to their original position. I hope you all know that. Still recapping, so this is about molding. And amniotic fluid is either meconium stained or clear or bloody, right? MCB. So either meconium stained or clear or bloody. So next part is what is the most important part of this. So whenever a parturient enters the labor room, her first plot will be on the alert line, because we have to be alert always. So suppose somebody is getting admitted at 12 noon on a certain date, 12:30 p.m. on a certain date. So we write 12:30 p.m. here, and then we plot her directly at a 6 centimeter dilatation. So we plot her directly at the 6 centimeter point. And after that we repeat PV every 4 hourly, like so after 12 it will be like 4:30. So if 4:30 she is 9 centimeter, so her plot will be somewhere here. So this is the wrong plotting, right? This is the wrong plotting. If we start the plotting from here, the right way to do the plotting is to plot it directly on the alert line. So wherever is the plotting on alert line, there we have to plot our 6, and that particular time point has to be marked as 12:30. So when after that, so at 4:30, if she is 9 centimeter, the line will be like this. So if she is at the left of the alert line, then she is progressing well, and we can just do routine monitoring. If it has crossed or on the alert line, then we have to remain alert, and if it at any point crosses the action line, then we have to think about doing augmentation or take action like cesarean. So these were the portion where you used to plot contraction, and there the oxytocin drop rate. This section was for drugs and IV fluids that was given, and this is the maternal This is the maternal segment. So it starts with the fetal segment, fetal heart rate, then comes the labor progress data and drugs and all labor related data, and then comes the maternal well-being. So maternal pulse, maternal BP, and temperature, urine protein, acetone, and urine volume, that is urine output. So this was the standard WHO new part. So here you can see a partograph of CPD. Here you can see the fetal heart rate is slowly falling. Fetal heart rate baseline is slowly falling. So basically there is an evidence of fetal distress. And if you can see, it is molding plus, 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 and now 3 plus. Liker has always been clear till this point. So here they have started plotting right from the alert line, and it remained always on the right of the alert line, keeping us at alert, and then it crosses the action line. Head descent was happening, and then at a certain point for last 3 PV findings, there is no head descent. So this portion has two parameters: cervical dilatation and head descent. Head descent in stations. Right? So you can see the uterine contraction is increasing, like 4 per 10 minutes. Now more than that, 4 per 10 minutes. And this color coding, the denser the color or the redder the color, the more contractile strength. You can see the maternal parameters remain more or less the same. So this is one of the partograph of CPD where the head is not descending for 3 consecutive PV readings, and slowly over the time the fetal partograph goes right of the action line, probably necessitating a cesarean. So now let us look at the new partograph. So this is the WHO labor care guide. So let us see section by section. If you can see the section, it is almost the same name, and then parity and all the labor onset data, then rupture of membrane, date and time, what are the risk factors, and active labor diagnosis date. Active labor definition has actually changed in this new, that we will come to discuss somewhere later. So now see what is the section 2. Section 2 is supporting care, right? So they are now talking about whether a birth companion, whether her husband or a close relative or whoever she wants is present during the labor or not. Pain relief, it was offered or not, epidural, entonox, or injectable opiates, whatever it is, or maybe simple things like water bath, music therapy. So oral fluid, if she receiving enough oral fluid, and what is her posture? So she can be at any posture she wants, not only bound to bed like supine. So these are the things the section 2 states about, and these are actually new, and this comes from the concept of respectful maternity care, RMC, respectful maternity care. This is basically a philosophy recently identified that it is not only the medical service of the quality should be there, but an holistic improvement in maternal care needs respect and autonomy of the mother, respect to her choices, and her psychological and holistic well-being, not only the medical well-being, right? So these things are new in this partograph. And note one thing, that active first stage and second stage was not there in the new WHO partograph, which is replaced by this one. This one is named as WHO labor care guide. So next section talks about the baby, just like previous one. So baseline FHR, if FHR is deceleration is there or not, color of the amniotic fluid, fetal position, caput, and molding. So these are the things this section sees. And section 4 is about the mother or the woman, right? So pulse, systolic BP, diastolic BP, temperature, and urine. So what are the alerting things? So if there is no companion, that is alerting. What is if she is not on any pain relief, then she is more likely to get exhausted or abandon the idea of pursuing for a vaginal delivery and opt for or ask for a cesarean. So these are the alerting things. If she is not drinking enough oral fluid, she will get dehydrated. That increases the risk of a dry labor, slow progress of labor, and dehydration leading to PPH. And posture supine. Posture supine bound to bed is not advocated in modern respectful maternity care, and she should be mobile. She should be either in lithotomy or in left lateral or in walking, all fours, sitting, standing, whatever it is, her position of choice versus supine. Right, so supine position denoted by SP is one of the alerting factor. Now baseline fetal heart, you know, if it is less than 110 or more than 160, if there are late decelerations, we had discussed in our CTG NST discussion, high yield topic discussion about the deceleration, why late is the worst. And then if there is 3+ molding, that's grade 3 molding, or there is, sorry, if there is heavy meconium stain or blood stain, that is M+++ or B. If fetal position is either posterior or transverse, because anterior position is most favorable. If there is +++ caput or +++ molding. So grade 3 molding basically that we have just discussed. So if maternal pulse is less than 60 or more than 120, if maternal systolic BP is less than 80 or more than 140, if diastolic BP is more than 90, temperature less than 35, that is hypothermia, or more than 37.5, that is 100 plus temperature in the mother, or urine showing protein plus plus or albumin plus plus. So these are the alerting features. So this alert column, instead of alert line, we will be seeing alert column in this new labor care guide. So if there are contractions, section 5 deals with the labor progress. Section 5 deals with the labor progress. So instead of the graphical representation of contractions, now they have shifted totally into numbers. No light dots for this and lateral bars for this. Like previously it was like if contractions are less, it will be represented like this. If contractions are stronger, it will be represented like this. If contractions are even more stronger, then by cross hatching. And if contractions are even more stronger, then full dark. And finally I'm using red as my marker, otherwise I could have shown you. If contractions are super strong, then this column will be marked with proper bright red, like you have seen there. So this is how things were subjectively described. Now in this labor care guide, contractions are mentioned, how many contractions per 10 minutes and duration of each contraction. So we write like 20 seconds each contraction, 3 in every 10 minutes. That's how we write it in our notes, labor progress notes, and mark it in the new age Partograph or labor care guide. So if it is less than 2 or more than 5 per 10 minutes, both are not satisfactory. More than 5 is hyper stimulation or at least tachysystole. Hyperstimulation means tachysystole with fetal distress. If fetal distress is not there, actually hyperstimulation is not said anymore. It is tachysystole, that is more than 5 contractions per 10 minutes with or without fetal distress. So previously with fetal distress it was known as hyperstimulation. If there is no fetal distress, it would be called simple tachysystole. So duration of contraction, if each contraction is less than 20 seconds, then it is not satisfactory contraction, suboptimal contraction. As if it's more than, each contraction sustaining more than 1 minute, that is danger sign, because that is overstimulation of the uterus, right? So next comes the most interesting part of the this new age partogram, is that in case of the previous WHO partogram, we assume that every mother at every case will progress like 1 centimeter per hour. That's why we put 2 lines at 45-degree angle at 4-hour difference to each other, named one as alert and the other one is action. But it is not like that. Someone might progress slowly in the first few centimeters and then rapidly progressing in the late centimeters, or maybe somebody was progressing too fast and later on the progress can become slightly slowed down. So it is the cumulative duration, it is the cumulative duration of the labor that counts at the end, and hence this labor care guide has mentioned, see, if she is at 5 centimeters, she should deliver within 6 hours. She should not deliver, she should go into second stage of labor in 6 hours. If it is 6, then 5 hours. 7 centimeter, 3 hours. 8 centimeter, 2.5 hours. 9 centimeter, 2 hours. So see, this linear thing was an error. Linear thing was a glitch. It looked simple, but obstetrics doesn't have like that, like 45-degree angle curve, standard equation, linear equation. Obstetrics is not like a linear equation. So now you think that linearity is removed and it is made more evidence-based, more scientific. One more thing you can notice here, that starts from 5, unlike the previous WHO new chart partogram, which if you have missed, you can find it my Facebook page Sunabha Ghosh, or my Instagram account where I post several flashcards at the rate DRSUNABHA, that is Dr. Sunabha, and all those topics are shared in your gamers club and game telegram group as well. So you can find those charts there. I have uploaded both these charts already, so you can go and see that the WHO new partograph starts at 4 centimeter, whereas this partograph starts at 5 centimeters. So basically we have liberalized the admission criteria into the labor room. We let them be in the ward till 5 centimeter dilatation, not like 4 centimeter dilatation like previously. That 1 centimeter also counts. And here is the descent, like stages, I mean station 5, 4, 3, 2, 1 and 0. So this is the descent plot. Section 6 is oxytocin, medicine and IV fluids. So we see that previously IV fluids were there, but now along with it oral fluid is also additionally added, and this is assessment and plan, and that has to be done in discussion between the obstetrician, maybe the pediatrician or neonatologist on duty, and the parturient and her partner, the parturient and their partner. So shared decision making. So this chart is basically made with the philosophies of respectful maternity care. So we'll see an example of a plotted chart. Here you can see, like, here companion was not there, but at other points companions are there. So the alert signs are marked with a red cycle. Here pain relief was not given, Other points pain relief was given. So those are not marked. Y means yes, it was given, and N means no. So N is a risk factor, so it is put as with red circles. Here you can see she is mobile, and at this particular point she is supine SP, so it is marked with a red circle. See, here the fetal position was posterior to begin with, so it was marked alert. Then it was transverse to begin with, so it was marked alert, and then it became anterior over time, so the alert mark is removed. So now alert is not just based on a single parameter, single graph, but multiple parameters. So here if you see this chart, there are 1, 2, 3, 4 alert factors, whereas if you see at this point of time there were 3 alert factors, and if you see at this point, that is only one alert factor, and that is at position supine. So like that you can assess actual, okay, what is happening in a multi-parametric way, right? So you can see here there was no molding, then slight molding appeared, then +2 molding appeared, but molding +3 is most critical, so there is no alert call raised here. Caput, it's generating plus. So small degree of caput and not important. Liquor was clear. Liquor was clear to begin with. So if you see the maternal parameter, it all looks good. And see now when she was admitted at, where is the time? Yes, 6 a.m. So she was plotted at 5 centimeters. She was admitted at 6 a.m. into the labor room and it was plotted. So she is supposed to deliver within 12 o'clock, right? So next is 4 hours later at 10 when we did PV, she is at 8 centimeters. So now she is 2.5, she should deliver by 2.5. Now from this point she should deliver in 2.5 hours. So the next PV is done roughly around 3 hours later or 2.5 hours later. So it is plotted at 1 a.m. So it is not 4 hour anymore. So this lady at 10 a.m. is supposed to deliver within next 3 hours. So the next reassessment comes after 3 hours, not after like 4 hours, like our previous chart, everything 4 hours, right? So we assessed after 3 hours. And then we understood that she has reached the 10 centimeter, that is full dilatation. So from here we start plotting second stage, and second stage we are plotting every 40 minutes. Like at 13:05 we saw she is supine, everything else looks normal, head is at +3 station. Then at 13:45 she has given birth. So that completes our complete partograph. See, at these points we have discussed all her issues, and here you can see the pain relief advice, normal progress, normal progress, normal progress, pain relief required, because at this point pain relief was not required. Then again normal progress, normal progress. So at each point the things what is happening to the parturient is communicated to her and to her close bys, near relatives, so that there is no communication gap between the labor room team comprising of mainly the obstetrician and of course the neonatologist. So see, this entire column of marking second stage, where is the descent, and what are the duration of contractions, like she's getting 50 seconds good contraction, so we are happy. So contractions for 10 minutes, it was 3 initially and then 4. We are happy that she has a companion around her. We are happy that she got adequate pain relief. She is drinking orally, so she is not dehydrated, but she is lying supine. So that is slightly against that makes us slightly alert based on this particular chart, but that is kind of acceptable, I think, in second stage. So this is the second stage monitoring. I have just made a zoomed copy here for your analysis, and I have zoomed this area, like here how the plot is done and how the head descent is done. So there is no alert line, action line just to guide that they have to, like, this is more individualized based on the maternal characteristics, how they should giving more liberty to the lady, right? So let us just briefly see what are the new things, because this slide is what is going to be asked in your exam mostly. So active phase in old, it is actually not old WHO partograph, it is the WHO new partograph, which has now become old because LCG chart, the labor care guide chart, has come. So active phase was considered at 4 centimeter. Now it has become 5 centimeter. It was always 1 centimeter expected progress, 45 degree angle of action. Now there is more evidence based and more individualized timeline. There was alert and action line. Now no such 45-degree restrained angles, like everybody should progress at a certain rate, that is removed. No second stage monitoring. I mean, there was no provision of monitoring second stage in the WHO partograph that we used to use. Now there is a scope of second stage intensive monitoring, including whether she has an attender, whether she needs pain relief, whether she needs to drink more water and all. So there was no recording of supportive care, no provision of respectful maternity care. So now we have included the philosophies of respectful maternity care, that is her posture, her pain relief, her oral fluid intake, whether she has a companion or not. I think this clears all your confusion, and since it's a new development, I think today or tomorrow this will be asked in one of the question, and INI exams are usually pioneers of asking this kind of things. So yeah, in INIs, like in JIPMER also, anything new comes, like our groups will be flooded, and then every consultant and every every consultant asking their senior PGs, and senior PGs are asking their junior PGs, and junior PGs are asking their interns, and then those things are in discussion. And when the questions are sent from these institutes, these things, like, they remain in the discussion. So these things are asked, right? And the institute candidates, they are also a part of this discussion during their rounds, during their classes. So that's how they get the advantage. That's how anyway. So the bottom line is, whatever is new is important for exam, specifically for INI exams, right? So I would like to highlight three things. Again, I told you I'll show you. So this is the WHO guidebook of labor care guide, and here you can see not only the woman in white with who is carrying her baby, but also her likely to be male partner in black, or some partner, I mean, yeah, not gender stereotyping, but one partner is along with us. So the supportive care, the support care, all this concept has been incorporated into the logo. Remember this logo, because this can come as your image based question. And along with that, this is WHO labor care guide. I would like to highlight on two more things. This is Government of India Ministry of Family and Health Welfare National Health Mission guideline. So this is Lakshya. So remember this logo as well. This is WHO Labor Care Guide. This is Government of India Ministry of Health and Family Welfare Mission National Health Mission guideline. This is Lakshya. This is Labor Room Quality Improvement Initiative. And there is one more initiative that is guided by Fmge, which is Manyata, Don't Forget Moms. And this is what mainly talks about. This talks about the labor room quality. This is a comprehensive chart by WHO, and this is what talks about the respectful maternity care on the national level from the national organization Fmge. So three organizations, three programs, three images, don't miss them. WHO, this logo, labor care guide. Government of India, Lakshya, about labor care, this is the logo. They have certain parameters, certain targets to fulfill, certain things to achieve. So this logo. And then there is Manyata. Then there is Manyata by Fmge. Manyata is by Fmge. So Manyata deals about respectful maternity care. I hope this has helped you. Keep following us, keep supporting us, and join the game revolution. Let's play the game.